In. All right, we can start. So welcome to TBoneTime, and I'd like to introduce our first speakers, Amy Giuliano, who's very well known to you from Mass Eye and Ear, and David Young, who is a otologist, neurotologist, and head and neck skull-based surgeon from Mass Eye and Ear. Welcome.
Thank you, Callie.
And
thank you so much, Dr. Jung, for joining us today. It's always great to have someone who's outside of radiology, but is also a temporal bone aficionado to be with us to give other perspectives. So we'll show 2 cases and we'll go right to it. So case 1 is a 41-year-old female with long-standing hearing loss in both ears. And her exam was unremarkable aside from the hearing loss. And here I will stop share and let Dave get on with his screen.
Okay, so I'm going to show you a short video that we put together. Oh, sorry, let me see here. This one. Okay, so, sorry. Okay, so I'm showing you a short video here of a stapedectomy, and I'm going to start playing it. Can everybody see what looks like this black instrument inside the ear?
Yes.
Okay, great. So, okay, great. I'm gonna start playing here. And what we've done here is raise what we call a tympanomeatal flap. So we have to turn the eardrum forward with this special instrument. And what you're seeing here is the incustostapedial joint right here. That's the incus coming onto the stapes, the stapedial tendon. That's the middle ear space. And this is a very common approach that we use for stapedectomy and other types of issues. And here we're using a special instrument to separate the incustostapedial joint. In otosclerosis, the stapes is fixed, and here we're using a laser to take down the stapedial tendon, and here the posterior crus of the stapes. We'll just make sure that's completely divided. And that will leave us looking with a relatively clear view, hopefully in a moment, of the foot plate. Here I'm removing the superstructure of the stapes. See, that's the anterior crus there, and the capitulum of the stapes. And now we're looking at naked foot plate. I'm using an instrument here to size up which prosthesis we're going to want to put. Ultimately, we make a fenestration through the foot plate that's fixed. So here I'm making a fenestration using the laser. I'm going to use another special instrument to kind of break up that char. Again, it's remarkable that not everybody goes deaf with this surgery. When we do it, we're using lasers right onto the vestibule, essentially. There you see perilymph just starting to come up. That's inner ear fluid. And here is the prosthesis coming in through the middle, into the middle ear. That wire will go around the incus, and we drop the barrel, the white barrel of the prosthesis, through that fenestration we've made, which now then reconstitutes the hearing mechanism. We're using the laser here to tighten up that little wire, and we'll suction here to prove to ourselves that barrel really is within the fenestration that we created, and that completes this you see how we tested to see how the barrel moves there. I'll suction in just a moment, I think, to remove that fluid to show that it's completely in place. Maybe we, and maybe we don't. In any case, sorry, let me just finish that off there. Once again, we show that it's moving. Great. And I will stop sharing here and cut back to Amy's screen. I went over that pretty quickly. Does anybody have any questions about how that's a very basic stapedectomy with the essential steps. There was nothing, strange or unusual about that procedure. I'm happy to answer any questions about the procedure itself.
I think as radiologists, we're just overwhelmed. It's just incredible what you do.
We think the structures are so tiny to see on a CT. Can you imagine putting fingers and instruments and being able to do it precisely? That's just incredible.
Yeah, that particular prosthesis we put in for her was 4.25 by 0.6 millimeters in size. That's a pretty typical prosthesis we put in.
Okay, so this is a slide, and Dave, please continue.
Excellent. So what this shows is an audiogram before on the left and after on the right. So let me just kind of walk you through this a little bit. The 0 line here close to the top is absolutely perfect hearing. So the further down you are on that on that grid, the worse off your hearing is. Anything above 20 decibels of hearing loss is considered to be normal. So 0 to 20 is considered to be normal. You see brackets and lines here of two different colors. Red refers to the right ear and blue refers to the left ear. The brackets refer to the inner ear function. So you see that the red brackets and the blue brackets are right around that 20 decibel line, telling us that the inner ear function is normal. However, where she's actually hearing via air conduction is decreased below those brackets, the blue line versus the red line. And so the goal of the stapedectomy is to try to improve the conductive hearing such that we bring the air conduction all the way back up to those brackets. So on the after line on the right, you'll see that the blue brackets in line are approximately the same. However, we have raised the red line significantly closer to the red brackets. However, not all the way back up to the red brackets. There still is a bit of a gap there, most noticeable at lower frequencies. And that's what we're going to be discussing for the rest of the session. Why might that be?
Okay, so now let's look at CTs, which we are more familiar with. So this is the right temporal bone, and you can see here that there is lucency. So abnormal hypodensity that's anterior to the vestibule in both locations and right at the front of the stapes footplate. Here is another finding, which is this lucency below or under the basal turn of the cochlea, coming out in front of the IAC, which is a location that's described where otosclerosis can happen. And I just want to contrast those with normal structures. In particular, we see this little notch once in a while, and it's been debated in the literature, but based on a case series we have here with histopath correlation, we term this the apple bite, and that comes from Dr. Curtin had mentioned this as the apple bite. So a little notch that we see even in normal patients with normal hearing. So that's fine, but this area can be involved by otosclerosis. And then for the blue arrow, this is the cingulate canal, where the cingulate nerve or the division of the vestibular nerve goes in here to supply the ampulla and the posterior canal. So the purple and blue arrows are normal, the red ones are abnormal. The left side, she also has similar findings. Again, there are hypodense areas that are anterior to the vestibule, anterior to the stapes footplate. And again, we see that abnormal lucency emanating from the internal auditory canal that's beyond the normal apple bite that can be seen in some normal population. So this is a pretty classic look for an otosclerosis. So that's why she went to surgery and had the stapedectomy done by Dr. Jung. So why is it that the red line didn't go all the way back to normal hearing afterwards? Well, if we were careful to look through the entire study, we'll find that there are actually additional findings. So here, you can barely see it on the axial. Here is the superior semicircular canal that's blending right into the intracranial contents without a good bony roof covering over it. The coronal shows it a little bit better, but not ideal. And that's why we do these reformatted images. So the post-shell is a reformatted plane that is completely parallel to the superior canal. So the entire superior canal opens up into a rainbow so we can see the roof. But in fact, the even better sequence is stenverse, which is perpendicular to post-shell. So now we're seeing the superior canal just down the barrel as a cross-section. And the finding that you would see is just that the very little bit above it may be gone. And so sometimes I think we do hedge a little bit to say the bony covering is not well seen, no wide defect, but we can't exclude a small defect. And just to take a look at this patient's other side, the left side similarly, not a really robust bony covering over the superior canal. The post-shell, yeah, maybe you can kind of see it. So one trick I've been told is that you can be pretty definitive about it. If the upper part of the canal on stenverse actually flares out. So instead of having it come together as an arc, it flares out a little bit, so you don't see the bone. So here, this patient actually has otosclerosis, but also bilateral superior canal dehiscence. And that's why after surgery, there still are symptoms of conductive loss. Dave?
Yeah, so this brings up an interesting question that comes up in our field every once in a while. Should everyone have a CT scan before routine stapedectomy? And for this particular patient, I did not obtain a CT scan before stapedectomy. And then the question arises, well, wouldn't it have been better to figure this kind of thing out, superior canal dehiscence, before proceeding with surgery? And particularly in our institution, it's not really a question of whether CT is readily available or not. It's extremely readily available, even within the context of a clinic visit here. The bigger issue comes in as to whether or not the radiographic dehiscence of superior canal is actually going to be clinically relevant or not. One thing that we do know and following more and more patients with superior canal dehiscence is that many of those patients actually, even though they have a clear radiographic dehiscence, is that they do not have the classic symptoms of superior canal dehiscence, which include conductive hearing loss and potential vestibular symptoms. They have the radiographic finding, but yet they have no clinical symptoms of the disease. And so the why that should be is not entirely clear. The thought is that sometimes the dura comes from below and creates what we call an auto plug. It's just enough, protruding enough through the dehiscence to prevent the patient from actually having symptoms. That's not entirely necessarily clear. And we do know, in addition to that, that the sound quality that one gets after surgery is better than the quality one would have from a hearing aid. So, you know, and that's the tricky part about this case is that because she didn't have a complete recovery of hearing, even or improvement in hearing, all the way up to what her sensory neural hearing might allow, she still is in hearing aid range even after the stapedectomy. So that's a little bit of the controversy here on whether to CT or not. So I personally generally do not obtain a CT scan if it's considered to be a routine stapedectomy, but some people do, and if they do see a superior canal dehiscence, they tend to steer those patients toward hearing aid and not toward surgery.
Thank you. All right, so the take-home point for this case from the radiologic point of view is that we always should follow a checklist for temporal bone. We look at everything and don't stop just because you see a finding. So in this case, you know, we report the otospongiosis, but we keep looking and we have to report the superior canal dehiscence. Conductive hearing loss, the causes are going to be in the middle ear because it's a problem of the sound waves traveling through the middle ear to hit the oval window. But the only exception is if there's a third window phenomenon where you lose the normal hydraulic, you know, pressures that would make it look as if the sound waves never arrived. So that looks like a conductive loss. And then for superior canal dehiscence, Stenverse really is the most helpful. Post-shell is okay, but for the really tricky cases, Stenverse gives you the most ability to scrutinize. And just to be cognizant of time, we'll do this quickly. Case 2, 58-year-old female with a history of stapedectomy both sides more than 20 years ago for otosclerosis with good conductive hearing result and now having progressive sensory nerve hearing loss. So here's the video and I'll just let it play. You can see abnormal hypodensity, right, around the stapes footplate. This person has had a stapedectomy, but also all the way around the cochlea. So you can see the circumferential look. So there's a retrofenestral cochlear component as well. And sometimes you see that sclerosis, make it pause, that's extending into the cochlea, and you can have the heaped up mineralized bone that goes into the space in the cochlea. And same thing on the other side. There's both fenestral and retrofenestral and cochlear otospongiosis. So both sides, so now there's a cochlear component, and that's where the cochlear implantation comes into place.
All right, great. So let me show you the video quickly here of the cochlear implant case that we did for this patient. And what we'll see here is that we've already drilled out the mastoids. You'll see the lateral semicircular canal off to the right. And what I'm doing here, or what the resident is doing here rather, is drilling the facial recess. It's about an aperture about 2 millimeters wide. You can see the white line right behind this drill that's going at 75K is the facial nerve. The vertical segment of the facial nerve is running right there. We're just entering the middle ear space. We're completing the drilling. And right here, actually, let me go back just a bit. I'm sorry, I went back by that pretty quickly. At this point, I would expect to see the round window membrane essentially through this view, okay? That's the type of view we have right now. But I don't see anything. I just see a blank wall of bone. So what I end up doing here is actually looking up and visualizing by drilling a little bit more superiorly the previously placed prosthesis. And that tells me that's right at the oval window. So that tells me kind of where I need to start drilling about 2 millimeters away to find where the round window used to be before it was obliterated. I'll let this play. And here we're drilling open the cochlea at that location. Now we're looking at the basal turn of the cochlea there. That's open, the cochleostomy. Here we're inserting the implant array, holding this in place. And we gently insert the array off stylet here. I won't bore you with the entire insertion. I'll skip forward here a little bit. And that's the electrode array in place through the cochleostomy within the new round window, in the vicinity of the round window. Stop sharing there. Okay.
Okay, thank you. Are there any of the questions that you would like to answer live? There was one from Shanaz. Oh, Amy, you've answered that. Are there any other questions that you'd like to answer live?
I just wanted to share really quickly the last couple of slides, or I can just say it.
Oh, no. Okay, let me just end share. Give me a second. There you go.
It was just a couple of conclusions. So the key to this case is that this is not only a fenestral and retrofenestral. Oh, am I sharing it? Can you see it?
Not yet.
Let me see. Webinar, share, yes. This here, share. Yeah, so the key to this case is that it's not just an otosclerosis, but it's obliterative. So it's really narrowing and obliterating the round window, which would make a cochlear implantation really difficult to do. So that's important to mention so the surgeons know. And last webinar, someone mentioned what we look for in plain films for cochlear implant to check the position. So this is that same patient who intraoperatively before the case closed, got a film so we can tell the surgeons, so we identify landmarks. Here you can see the superior semicircular canal. Here's the lateral canal. Here's a bit, probably maybe the internal auditory canal, and you can see the cochlea is in its expected location. Here are two other patients, so it's all by landmarks. Here's the IAC, superior canal, lateral canal, so the cochlea should be below the level of the vestibule and between the IAC and vestibule, forming a 360 degree or sometimes 270 degree turn, so there are enough electrodes that are within the cochlea to be able to stimulate the hair cells. Another patient, again, superior canal, IAC. And here's actually a case where the tip is coiled and bent over itself, so that's not okay. We would tell the surgeon so they can adjust it before taking another film to confirm good position before closing the case. So the take home would be, look at the round window and always report on that with cochlear otospongiosis. Is it obliterated? Pre-op imaging, we're looking for anything along the path that might preclude a smooth cochlear implantation. So any findings along the calvarium where the implant sits, mastoid middle ear disease. Is the facial nerve going to be injured if the bony carping is not intact? Is the round window open? And is there labyrinthitis ossificans? So it may be hard to push the wire through. And then anything that might make the patient not be able to hear, even with the implant, such as a cochlear nerve aplasia and cochlear anomaly. And that's it for us.
I have a quick question for David. Hey, David, so do you believe in the extended facial recess approach for cases like this? Or, you know, I mean, or is that the same as a cochleostomy?
Yeah, so actually, a classic cochleostomy is actually made in a separate fenestration anterior inferior to the round window itself. So that's old school how Nadal and Roush used to do it here, okay?
Mm-hmm.
I will commonly take away bone in continuity with the round window to drop myself below the hook, and that's what I like to do to kind of give myself a little more space. If I'm really trying to preserve the hearing, I'll use a more of a floppy electrode and go a pure round window, but it kind of depends on the situation. But most commonly, I will be doing an extended round window cochleostomy, yes.
Okay, great.
It's just a little bit of semantics.
You're right. Okay, thanks.
Thanks.
And there are a fair number of questions if you want to answer them in the chat box. And CBCT is cone beam CT.
Oh, great.
And there's also one question in the Q&A. Okay, so I figured I'd show some companion cases. And in fact, there've already been some questions regarding some of these entities. So what is our approach to otic capsule bone lucencies in children? What do we see commonly? And then also, let's look at some very rare and unusual cases. So the first question that came up was, can the cochlear cleft be mistaken for otospongiosis? And so we'll look at some cases and then discuss whether it should or shouldn't be confused. So far left, this is a cochlear cleft. This is extremely common and it's considered a normal variant. Next up is a pediatric case of otospongiosis, very uncommon in kids. And then the two right-hand cases are kind of once-in-a-lifetime cases that we found very difficult to know how to approach. And so I want to share with you our experience in case one of you should ever see something similar during your careers. So regarding the cochlear cleft, this has been very well characterized. And it's a very thin lucency that you'll see most typically just along the the medial aspect of the cochlear promontory, between the outer aspect of the bone and the cochlear turns. And the key points about this lucency is that it should be very thin and very sharply defined. You don't want to see fuzzy borders. And you can sometimes see it also a little bit medially. And in terms of when it occurs, it is invariably present in infants, and in fact is seen in about 2/3 of kids under the age of 4, and then gradually ossifies over time, but can persist through young adulthood. So this actually is a 22-year-old patient. Interestingly, this little block here is from this book, which went out of print as Amasis became owned by Elsevier. And funnily enough, in Amazon, it says the book was published in 1726, which is kind of funny because CT wasn't around then. And the funny thing also is that there was one rating, and that you can buy the used copy for even more than the current unused copy at present. Anyway, so these are the key facts about this normal common variant. Also, interestingly, look who has published. Our wonderful colleagues from Mass ASHNR with a colleague of theirs from Lithuania, who showed not only the specimen here with the pericochlear lucency, but corroborated the fact that this lucency occurs due to incomplete formation of endochondral bone, and it's a small little lucency containing fatty material. So it's considered a normal variant. And then the other thing that has been mentioned is that this is clinically inconsequential. So don't worry about it as long as it is following the rules of being very thinly defined and sharply defined. Now, on the other hand, many of you who follow social media will have seen this post by Christine Glastonbury, where she says otosmugiosis, which is what a fellow called otospongiosis. So it's kind of relevant. I see some folks in the chat box who are really talking about this new terminology. So anyway, otospongiosis we typically see right here up against the vestibule, and it's very uncommonly seen in kids. And I would say that I worry that we're missing cases because we don't expect to see it. And so people are very focused on looking at the ossicles and looking for third window effects in children. And they must remember to look carefully for otospongiosis, which is another cause of conductive hearing loss. And there are reports of this in the literature. Okay, now finally moving on to the unusual cases. So I think most people will recognize that this appearance here of very extensive pericochlear lucency in a child would be infrequently due to otospongiosis. And here we are usually dealing with syndromes. And so those who do pediatric radiology will be used to looking at a search and will be wondering whether there's a problem with bone formation, and the next thing they'll look at is the skull for Wormian bones, and then they might go and look for other bones to see if the patient could perhaps have osteogenesis imperfecta, which is perhaps the best known syndromic cause of this degree of lucency. And interestingly, when it comes to OI cases, it's usually osteogenesis imperfecta tarda that causes the pericochlear lucency, in these patients the diagnosis of, true OI may have been missed. They just may have been thought to have multiple fractures without actually appreciating that they have OI. However, in this patient, there were a variety of very unusual phenotypic features, including abnormalities of the hands, a little bit of prognathism, and then mid-aortic stenosis. And so what we usually do is when you have these really difficult cases, oftentimes the temporal bone finding won't necessarily have been described in the literature, but if you go into the website OMIM, Online Mendelian Inheritance in Man, and type in a few descriptive characteristics such as, the vasculopathy and so forth, then you can usually come up with a possible range of differential diagnoses. So in this patient, this is an unusual syndrome that I have never heard of before. It's a connective tissue disorder. Believe it or not, there are reports of the literature, even including temporal bone findings, a couple of reports here itemizing an otospongiosis-like finding, as well as ocular anomalies. So that is a very unusual syndrome. The diagnosis, I had this case in my teaching file as otospongiosis, and it was only 7 years later when I followed up the case that I realized that the geneticists had hallucinated the genetic mutation and made this confident diagnosis using this mutation. This case was even more unusual. So this patient was diagnosed on fetal imaging as having probable osteogenesis imperfecta. You know, it was noted that the bones were very bowed, and postnatally that was indeed thought to be the diagnosis. However, very close follow-up and testing from the geneticist failed to reveal any of the known mutations associated with OI. And the other fascinating thing is that very shortly after birth, so you can see this is pretty soon after birth, really prominent Wormian bones that you'll see in OI and skull flattening over here. You can see this incredibly abnormal attenuation of bone and Wormian bones and sort of fracture-like entities around the temporal bone, and a lot of lucency involving the otic capsule bone. Well, then the patient went on to develop this really pronounced swelling of the maxilla and mandible. And usually when it gets to this point, I'll just throw up my hands. I'll ask all of our oral colleagues and say, does anyone have any clues to what this is? And then we'll all put our heads together. And then I start emailing around the country and usually ask Sue Blazer or Bernadette. And nowadays I WhatsApp Amy, Gull, and Felice. And at some point we'll all just say, none of us know what's going on. And so they looked in this patient for a variety of things, including juvenile Paget's, and really didn't know what to make of this condition. Well, it turns out that it was the pathologist who said that the maxillary and mandibular lesions were cemento-ossifying fibroma, and that she was aware of 2 reports in the literature associating these very prominent jaw lesions with osteogenesis imperfecta with a known underlying genetic mutation. So again, very, very rare, once in a lifetime. Look here at the bones, here at the ossicles and how radiolucent they are. But one of you may see a case like this at some point in your career, so I figured I would just share it. It's pretty unusual. Okay, so those are my cases. And any questions so far before we move on to our next presenter? So this entity is known as nathodiaphyseal dysplasia, severe atypical presentation with known genetic mutation of osteogenesis imperfecta with these very prominent fibro-osseous lesions of the jaw bones. And interestingly, this patient is now age 20. I've been following up this patient since birth. He's actually doing reasonably well, and the jaw lesions have regressed over time.
There is a question from Leandro, who asked if this is related to cherubism, because of it looks like that a bit on 3D.
Yes, so good question. That was actually one of our first suggestions when we saw the bone lesions, and they looked for the genetic mutations associated with cherubism, and they were negative. And it's interesting that our pathologist, her comment was that there's a differential for the fibro-osseous lesion, but that she found cementicles, which enabled her to call it a cementifying ossifying fibroma, and then she could tie it back in with the osteogenesis imperfecta. But yes, we thought that the maxillary and mandibular lesions were cherubism. When that came back negative, we wondered whether there was disruptive calcium and phosphate metabolism. And then, you know, they also sent off a mutation for juvenile Paget's, and every single thing that they sent off was negative. And then, unfortunately, by the time we figured out what the diagnosis was, the geneticist who was following this patient had gone to the West Coast, and the patient elected to stop following up with genetics. So I don't think they eventually did the final genetic mutation analysis. Okay, handing over to Felice.
Okay, let me share the screen. All right, so this is, I have two short cases, but they are about a special one that I like very much, and this is the cochlea. So the only thing I have to apologize for that I know that there are over 320 T-bone enthusiasts, but I will show some brains today because we like to connect the dots. And this is the first case. This is 1 month-old male with congenital cataracts and intractable seizures. And let me go on my, oops, no. Oh, okay. So yes, so this is the brain I was speaking about. And now you can write it down in the chat, what do you think it is? Because these appearance of the brains are extremely characteristic. And this is a scan, not from my hospital, it's part of a study that we just had accepted. But this was a fantastic children's hospital, and they, of course, got the diagnosis right. You can see there is this malformation of the cortical development, quite diffuse. There is encephalocele here, but look at the brainstem as well, and the cerebellum is abnormal, okay? Now, this is the sagittal view, and there is this typical kinking of the brainstem, so it's Z-shaped brainstem. I'm sure that someone already say in the chat, it's not carry 3. Yes, so Darag and Ayman are right. This is a Walker workbook phenotype. So this is alpha dystrophicanopathies, and this is the worst phenotype, typical Z-shaped brainstem. Now, what we had also this sagittal, but they also did cysts on the midline to check for the midline structure and to better see the to better analyze the midline structure here, the characteristic of the encephalocele and so on. But what you can do with this, which is only midline, you can reformat. And if you reformat that, there is something very weird. Look at the cochlea. Okay, it's not completely included, but there is the basal turn and just a bit of apical turn that is displaced anteriorly. You can see the lamina spiralis here. It's not the great scan, but this is the funny part of these cases. Lamina spiralis is here. There is basically just a bud, a small vesicles that represent the apical part of the cochlea. So you have a normal basal turn, you don't have the apical turn basically. And if you look at the T2, because here we missed all the other part of the cochlea, what you have is that the remaining part of the inner ear, so the vestibule and lateral semicircular canal, are completely okay. So let me come back to the presentation. What we did, we saw a lot of cases with my friend Giacomo Talenti, with Kelly, a lot of cases with alpha DG, in particular Walker Warburg, but we also had Fukuyama, and we also had muscle A brain disease. And what we found is that all the Walker Warburg, they had exactly the same appearance of the cochlea. This is done by our 3D department. They have a 3D printing. They work with MaxFact, but this is the 3D reformat, and you can see the fact that there is basically no middle and upper turn. And this is technically what is being called by Senarogo a cochlear hypoplasia type 4. Why is this important? Because we have a normal development in the type 4 of the basal turn. And why this is important, there is this amazing paper, the title is fantastic because normally when we write it, we are quite boring, that basically shows how there is a polarization in the development of the inner ear, and some genes are working in the anterior medial part of the otic capsule, i.e. the cochlea. Some other genes are more involved in the vestibular semicircular canal. So we have here only a cochlear malformation, and we know also the timing of the development of the basal turn. So we have a lot of information in this case. These are genes only involved in the cochlea, and which can be PAX, OTX, sonic hedgehog, which is stimulating the cochlear development. And we know that there is a very weak genotype-phenotype correlation in alpha-dystroglycanopathies. So we have Walker-Wall group is a phenotype which can have a lot of genes, and these genes really overlap. So looking at the ear really can help us in, because of course in this case the fact that the child is deaf is not very important given the complexity of the brain and findings, but it's very important to understand the genotype-phenotype correlation, and sometimes the answers are in the cochlea. This is what we wrote in this paper that hopefully will be published soon in ASHNR. It is possible that the cochlear hypoplasia type 4 morphology in patients with Walker-Warburg is due to a genetically determined arrested development between the 10th and the 20th week of development, because this is where the basal turn is fine and is developed, and the upper part of the cochlea starts to develop, and associated with genes that are only involved in the cochlear embryological development. So this we thought is an observation only, but it's very, very interesting because we don't know enough about the inner ear development. We don't know enough about the genotype-phenotype correlation of Walker-Warburg. And on the same line, along the same line, this is a 6-year-old female with dystonia and oromotor deficits. Again, I will show you the brain, if you can let me go back to my, so this is the first. So look at the brain, and again, guys, try to do the diagnosis. I will be a bit slow because there's something wrong in the ear, you already see. Maybe cerebellum, slightly dysmorphic. There's something missing here, something strange here. And this is the axial view. And this is the sagittal view. So now, who wants to do the right diagnosis?
You want to show us those temporal bone pics again?
You mean on the axial T2?
Yeah.
Yeah. Yeah, this is the temporal, and this is the only thing I have in this case, plus I will show you some other cases. So, okay, is syntelencephaly. So someone saying about septoptic dysplasia. Septoptic dysplasia is a misnomer because in this case, this is due to the, first of all, there is no association, strong association between absent septum pellucidum and abnormality in the optic nerves and the pituitary region. So you need to call it probably optic nerve hypoplasia syndrome because the associations between the optic nerve development and the pituitary development. Then you can have associated abnormalities in the septum pellucidum, corpus callosum, cortex, and so on, and they call before SOD+. But remember, the septoptic dysplasia is a misnomer by the embryological point of view. In this case, it's because you have, and this is right, a syntelencephaly or interhemispheric variant of holoprosencephaly, that there is a traction effect during the development. So because of the way the corpus callosum developed, which is linked to the way the septum pellucidum developed, you have absent septum pellucidum. But of course, the observation is right. What is here is, however, that we don't have fancy images, but we can see that, okay, vestibule is slightly abnormal. There is this plastic lateral semicircular canal, probably superior and posterior are still okay. The cochlea is completely gone. So in this case, some genes needs to be involved that are involved especially in cochlear development, but also in the rest of the inner ear. And what is very interesting is that you look for, in literature, and you have another case from literature showing incomplete partition type 1. I showed you last time the incomplete partition type 1, and you see there is no internal structure. Here there is persistent enlage of the lateral semicircular canal, which is completely fused with the vestibule without the so-called bony island, although ENT do not like this term, but this is a radiological useful term. And in this case, this is our case with a cochlear aplasia. So you look at the literature and you have that this is to syntelencephaly, you have basically that there is this mutation of ZIC2 that is one of the mutations that is involved in holoprosencephaly and encephaly, sorry, in particular in syntelencephaly. But keep looking at the literature, you have also that these ZIC genes are required for the morphogenesis of the inner ear. So you need to connect the dots, and I really think that there are some answers that the analysis of the morphology of the ear, not only the inner ear, but mainly, I have to say, can give us about associated abnormality in the other organ systems. And this is the case report from the neuroimaging part of images part of the neurology. And you can see the syntelencephaly with the abnormality in the inner ear. And this is a beautiful paper about the role of ZIC genes in the ear development. And they say that ZIC2 actually is involved with PAX2 and GBX. And PAX2 is involved in the cochlear development, so explain the fact that this child had one cochlea was completely absent. We don't know why it was asymmetric. And GBX in the development of the vestibule and semicircular canal, which can explain why there was an abnormality in the semicircular canal. So I found very fascinating this connection between the ear and the other part of the body, especially, but not only the brain. And if you are interested, sorry for self-quoting, but we try to summarize all these things with some friends, you know, Eser Samberdi, who was the author of this paper on cochlear cleft that Kelly showed before. And then William and Susan Blazer, Giacomo Ajay, so a group of people that like temporal bone, and we try to find all the association we try to fit the histological classification with the genetic knowledge that we have and with the other abnormalities in the other part of the brain, of the body, including the brain. So if you have a case like that, if you see something wrong in the inner ear, think about the bigger picture and send me an email. And this is Iski Island, because I keep promoting my region. So when the emergency will be over, please visit Campania. And this is a beautiful island. And if you have any question, I would be very, very happy to take them.
Thanks so much, Felice. And now over to Gul.
Thank you. Sorry, you guys can see me. I'm
Yes.
going to share my screen. And my cases are going to be very common bread and butter type cases. So hopefully that'll be a nice contrast to the awesome cases that we have seen so far. So this is our first case. This was, you know, I think a mid-20s woman who presents with vertigo. And actually the vertigo started about 2 or 3 months ago. She was relatively normal before that. So starting to look at the CT scan of the temporal bone, we noticed that there is some soft tissue in the mesotympanum, medial mesotympanum, abutting the tympanic segment of the facial nerve. There's a little bit of mastoid opacification, and there's some other sort of globular areas here in the adductus ad antrum. And as we keep going down, again, a little bit of more soft tissue in the middle ear. And we don't stop, we keep going down. And now we start seeing a lesion in the mastoid tip on the right, which has these sort of multi-globular components. And as you can see, the medial wall is markedly thinned, almost dehiscent. And the septations are destroyed, and they're, you know, essentially gone. So, you know, we're dealing with an expansile lesion of the mastoid tip, and the CT on the coronal view shows the lesion again to good view here. And so we're dealing with an expansile lesion of the mastoid with some lobular soft tissue in the middle ear, as well as mastoid opacification in somebody who has vertigo. So the differential for expansile lesions, as we know, anywhere in the temporal bone, one of them is going to be, you know, cholesteatoma. You can get cholesteatomas which can expand, or a cholesterol granuloma. Thirdly, I mean, if the lesion was more medially, you would think of things like an aneurysm. You know, what do we do when we are in trouble? We ask for the next imaging study, and so we got an MRI. So by the way, these were all like outside studies. So let me just show you. So this was not a IAC study, but I think it's good enough to answer our question. So this is a T1 weighted sequence, and we start seeing that there is some T1 hyperintense opacification of the mastoid air cells. And then as we get to the actual lesion in the mastoid tip, it is markedly T1 hyperintense, and it has a rim of hypointensity. Middle ear lesion, it's really hard to see. It was really not done as an ISC protocol. And on the T2 weighted images, again, nicely see that hypointense rim. And that rim is, you know, suggestive of either some sort of hemosiderin or that's preserved thin bone. The other interesting thing is, had a DWI sequence, and as we keep coming down, notice that there is definitely a component of restricted diffusion within the lesion, although there are some parts which are not. So this is sort of a classic differential and you know, expansile lesion differential. And this is on, if you see something that's bright on T1 weighted images, it's pretty much cholesterol granuloma, unless you know, proven otherwise. So what is cholesterol granuloma? So these are expansile round or ovoid cysts containing cholesterol cysts, cholesterol crystals, and there's some foreign body giant cell reaction and chronic inflammation, and many of these lesions have a thick fibrous capsule. So there are two theories. The more traditional theory is that these form due to obstruction. So when you have a eustachian tube dysfunction, it causes swelling of the mucosa and blockage of the air cells. So that entrapped air cell is resorbed, and so you get a negative pressure buildup, mucosal edema because of that, of the negative pressure. That results in blood vessel rupture, which is the main event, which results in cholesterol deposition, and then finally a foreign body granulation reaction to the cholesterol. And the newer theory, which is in the last 15 years or so, is called the exposed marrow theory. And essentially what this postulates is as the air cells are developing in a young child, somehow there's a communication between the mucosa and the overlying spaces. And that results in and this bone is really highly vascularized at that time when the child is growing. And so you get basically hemorrhage from this exposed bone. And then that results in granuloma. You get repeated hemorrhage. I mean, I guess this theory kind of helps explain the fact that many of these, Petrous apex cholesterol granulomas tend to be in well-limitized, Petrous apices. So, but anyway, so those are the two theories. Location-wise, the classic location is in the Petrous apex. And these patients can present with these symptoms, hearing loss, tinnitus, vertigo, hemifacial spasm, trigeminal neuralgia, kind of non-specific symptoms. In the middle ear, these patients can get blood, hemotympanum, and because of that, they can get conductive hearing loss. Traditionally, the mastoid cholesterol granulomas are thought to be less aggressive, and so they don't have that more expansile appearance that we see with the Petrous apex. But our case was essentially, looked like any other aggressive cholesterol granuloma. So this is just an example of a kid who had conductive hearing loss and hemotympanum. And on MRI, really what you're looking for is something that's T1 hyperintense. And so there was, this was a cholesterol granuloma, and also had some surrounding, granulation tissue with enhancement. And this is just your classic lesion at the Petrous apex with, again, T1 hyperintensity and hypointense rim. DWI can be variable. Like in this case, it wasn't that restricted, but the case I showed you earlier, there was definitely components of restricted diffusion. These are giant bilateral Petrous apex cholesterol granulomas, and one of the treatment methodologies is endoscopic drainage. So this is a case in which endoscopic drainage is performed through the nose. Another case, pretty much a copy of the case I showed you guys today. And so these can be a little bit more aggressive. And this is a cholesterol granuloma which developed in a mastodectomy cavity. So the general theme is T1 bright, expansile lesion, think of cholesterol granuloma. So that's my first case. Now let's go to our next case. So I'm going to close this one.
And Gul, while you're getting up your next case, Dave Yusum asks us, what about white epidermoids?
I think those are possible also. You mean, yeah, I mean, those are very uncommon. I haven't seen that many. I don't know whether Amy or Felicia, have you seen? I can't say that I've seen more than one in my whole career. So that's why I kind of discount it. But Amy, have you? So essentially, white epidermoids are going to be lesions which can be bright on T1.
Yeah, it's interesting. We see them more in the soft tissues around the nasal region. Then you'll see them, but not in the temporal bone, peculiarly enough.
But I think
the management will be similar. You operate on an epidermoid anyway because of the local expansion, so probably it does not change too much. I have a question. I have some problems sometimes we have something that looks like a cholesterol granuloma, but it's small. There is a possible erosion, but the apex is very pneumatized. And sometimes it's difficult to say this is just hyperintense fluid, proteinaceous fluid trapped there with some mixed signal inside or a small cholesterol.
Yeah, that's a great question. So in the Petrous apex, one of the classic sort of differential diagnostic entities is an effusion in the Petrous apex, which can be T1 bright because of the protein. So in those cases, I'm essentially looking to see if there's any erosion of the septations, and also looking to see if there's expansion. So usually these Petrous apex effusions tend to have no erosion, and they tend to be not expansile, but there is definitely a continuum. I feel like there are some Petrous apex effusions which go on to develop into cholesterol granulomas. So, so in those cases, I just, tell them to get a follow-up examination.
Yeah.
But the most part, if I see, especially if the patient is symptomatic, and if I see somebody, if the study is done as an MRI brain or a CT brain for something else, then I just call it Petrous apex effusion, if they're lacking the more aggressive features, and then just let it go.
Thanks.
All right, so this is our next case. This is a young child who presented with a history of chronic otomastoiditis. And so let's start by looking at this CT of the temporal bone on the left side. And as we look through, starting from the top, we've already started seeing that there's a little bit of erosion here in the anterior tegment tympani, and also erosion into the superior semicircular canal. And then we start seeing a lobulated lesion in the attic or epitympanum. And as we keep coming down, that lesion pretty much stops. And then as we are coming down more inferiorly, we start noticing that the head of the malleus is not very normal. It's partially eroded. And there is this little 1 millimeter density sitting next to the manubrium of the malleus. The tympanic membrane looks like it's retracted, and I'll show that on the coronal. So there's a bit of, so there's a little bit of a retraction pocket here. And going back to our epitympanic lesion, that's definitely, it's real, it's lobulated, and there is definitely a fistula into the superior canal and also into the middle cranial fossa. So, obvious things being obvious, this is a pretty good picture for a cholesteatoma. The other finding here is that if you notice that the scutum on this case, the scutum is eroded. And we're not really seeing anything in the Prusak space per se. So if you compare the scutum on the left side with the normal scutum on the right side, that's nice and sharp. So what we are dealing with here is something that we call an autoadicotomy. And so what's happened here is there probably used to be another cholesteatoma in the Prusak space or the lateral attic, and it's sort of auto-evacuated. The patient performed his own surgery essentially, and this scutum has eroded, and so it's left this sort of very classic deformity of the bone here, and this is called autoadicotomy. So this is a good example of a epitympanic cholesteatoma with superior canal fistula, tegment fistula, autoadicotomy, and maybe a tiny little cholesteatoma in the middle ear cavity, adjacent to the the manubrium of the malleus. Now we got an MRI, and MRI was helpful. So we can just show you guys the restricted diffusion on the on the DWI images. So these are non-EPI sequences. This is a haste sequence, and this is the cholesteatoma in the epitympanum. But as we keep coming down, there was also this tiny little focus of restricted diffusion, which actually corresponds to this little guy. So this is probably the smallest focus of restricted diffusion I've ever seen on DWI sequences. So, so this is an interesting case where we have two entities. We have an autoadicotomy from a previously evacuated cholesteatoma, and we have one larger epitympanic cholesteatoma and one smaller, tiny middle ear cholesteatoma. So I figured I'll just talk a little bit about autoadicotomies because we have actually done some work on that from when I was at Mass Eye and Ear. So this is what a conventional attic cholesteatoma will look like, right? So you have a lateral attic cholesteatoma with erosion of the ossicles, and the lateral epitympanic space is expanded. And if you can imagine that this cholesteatoma then decided to just evacuate itself, what kind of deformity are you going to be left with? And that's what we showed in this paper. And as you can see, this is the normal coronal and axials, and this is the autoadicotomy images. And the lateral attic is pretty narrow, but in patients who have had a prior autoadicotomy, it's expanded. And the scutum is sharp, whereas the scutum is completely gone. So I guess the point is that if you see this appearance, you can sort of guess that this patient has had a prior cholesteatoma, and you can alert your otologist to that. And this is when the process becomes even more extensive. So this patient has not had any surgery, but this patient performed their own mastodectomy, you know. So you can see that the entire mastoid is eroded. It looks like a cortical mastodectomy, but this is something called an automastodectomy. And this really is the shell that's left behind. So if you remember the histology of cholesteatomas, it's got this central sort of keratin debris, which is acellular, and then you have this sort of more active squamous epithelium, which erodes bone. So what happens in this case is that the epithelium is still left behind. It's also known as a mural cholesteatoma shell, and the keratin has sort of evacuated. So this is an automastodectomy, also known as mural cholesteatoma shell. So take-home points for today would be DWI may be bright in cholesterol granulomas. Your money shot is your T1 weighted image. And autoadicotomy appearance suggests previously evacuated cholesteatoma. And this is a nice little chart I think might be helpful. So I think T1 really nails it. T2, they can be kind of similar. There's no enhancement with cholesteatomas. Cholesterol granuloma kind of NA because you know, they're T1 hyperintense, so it's going to be hard to look for enhancement. And cholesteatoma is definitely restricted, but cholesterol granulomas may be restricted. So that's the end of my presentation. Thank you. Back to you, Callie.
Wonderful. Thanks so much, Gul, and thanks to everybody. Thanks so much to David for joining us today. We really enjoyed your videos.
Yeah.
Are there any other open questions from our participants? Okay, well, if not, thank you all so much for joining us.
Just
And
remember about the YouTube channel.
we will be, yep, this has been recorded and it will be posted on the YouTube channel. Just a couple quick reminders. The ASHNR Talking Heads and Necks webinar is tomorrow at 3 p.m. And you can hear Christine Glastonbury and Rick Wiggins speaking respectively about cranial nerves 5 and 7. And then also the ASHNR online virtual meeting will be held in September, the second week of September, just following Labor Day. You know, registration is much reduced, so we hope to see many of you joining us for that as well. And the content for that will also be recorded for those who have registered to be able to view at a later date. So thanks very much, and we'll see you again towards the end of September.
Thank you. Bye.
Bye.
Bye.